Thank you, Kim. Thanks to Sean and our organizers and the association for having us back in person. It really was missed for a number of years. We can talk into Zoom all we want, but it's never the same as being in the same room with people. So I'm going to talk today a little bit, and I'd like all of you to make believe you're here with Willy Wonka, and you're now going to go into this chocolate factory, chocolate not being on the allowed list. I want you to use your imagination, and that we're going to talk about what may be a cure and how do we know we're there. So I'm basically preaching to the converted. Those of you who are here are on treatment for your Wilson disease, those of our patients. But we define things in certain ways. So treatment, the actual definition, is the management and care to prevent, cure, ameliorate, or slow progression of a medical condition. Now you'll notice the word cure is in this list of what treatment is, but not all treatments are cures. Some keep a disease at bay. Some can reverse some of the symptoms, but not everything is a cure. And when we think of a cure in terms of an actual strict definition, there's really two parts that stick out, at least to me. One is they talk about a recovery or relief from a disease. And the second is it's a complete or a permanent solution. So that's the difference between a cure and a treatment, is really the permanence as well. Now, you've heard some really nice talks this morning, earlier, talking about the underlying basis of Wilson disease, but I'm going to boil things down to this one slide. And this was taken from a publication back in 1974, where they first started to look at what comes out in the intestine from our liver that puts it into bile. And they were collecting bile in patients with Wilson disease, and they're collecting bile in non-affected individuals. The upper line that you see here are all the non-affected individuals, and what you see in the lower line is the basis of the disease and actual translating it into what it means. That means copper does not get out of the liver in the normal fashion. It's not zero, otherwise this disease would be lethal in the newborn or neonatal state. So we do have other mechanisms that compensate a little bit when the Wilson disease gene is not functioning. But this is the reason, that difference between the upper line and the lower line is why over time the copper does accumulate and then leads to much of the signs and symptoms that were talked about. Now, when we think of an untreated patient and what is the natural history, what we're looking at is a timeline that starts on the left and goes all the way to the right. We begin typically with inflammation within the liver, then signs and symptoms of liver disease, then more advanced liver disease, and then somewhere in typically 10 years or more after the initial effect on the liver, you'll start seeing changes that may occur outside of the liver. In the brain, central nervous system is the site where we may have either neurologic or psychiatric symptoms may occur. And you then, if you continue along the continuum without any other interventions, you'll have complications from the advanced liver disease, liver failure, and die. When we think about a cure for Wilson disease, we really talk about the two parts, that recovery from the disease, which is really moving the timeline anywhere where you start over to the left, and then prevention, which is really no more movement on the curve to the right. Now, there are various different touch points in which we can modify copper metabolism in our body, and you'll just pardon the little cartoon that I have here. It's just sort of a way of thinking about it. We have the diet that can be managed in terms of the amount of copper that goes in. There are manipulations to the gut in terms of things like zinc treatment, and now we know trientine and even touch-thiamoliptate also block copper absorption. And then there's the way to take copper out of the bloodstream, and the molecules like trientine and penicillamine that were mentioned that help put that out through the kidney into the urine. And then we have other touch points that haven't been explored in the past that are now in the more recent setting being considered. and we'll talk about what might manipulate that curve that I showed you before, that amount of copper going out in bile, because I think that is one of the areas where we have opportunity. So how do we achieve a cure? I think we have to focus on that underlying problem of the copper accumulation. It may not be the exact amount that's there, it's where it is within the cells that may be damaging. That's probably more important. But that said, we have to take care of it where we can reach it. And where we can reach it typically right now has been within the circulation. And what we aim to do is also reach it within tissues as well. Now, in the circulation, the copper is mostly bound to the molecule protein albumin, and that is not a very tight binding, and that's on purpose so that we can extract it in our other tissues and use it for our metabolism. And then once it's within tissues, there's another peptide known as metallothionein, which is a small molecule which has a very tight binding to copper. Now, some of the metallothionein can be sequestered or move into safe places within cells, but sometimes you exceed that capacity. When you exceed the capacity, you have those injurious mechanisms that Dr. Toe was talking about before that lead to the tissue damage. And then we have another complication. We have a barrier that exists between our systemic circulation, that's all our blood vessels running around our body, and the circulation that goes through to the brain. It's what we call a blood-brain barrier. So when we talk about getting copper out now, we're currently bound by what we call more of a gradient, a diffusion from what's in the central nervous system, getting it back out into the systemic circulation. None of our current therapies go directly into the brain to pull the copper out. It's an indirect mechanism. So how do we get rid of the excess copper? As I mentioned, we work on what's circulating, that sort of excess bioavailable or non-ceruloplasmic copper, and there are various different chelation agents that do that. We can have indirect reductions by blocking the gut absorption. And then now there are coming along now in 2024, the ability to consider novel agents that enhance biliary copper excretion, getting to that underlying defect in when ATP7B doesn't work. And you're going to hear more about the gene therapies, in particular from Dr. Ascari, an area not touched upon perhaps is gene repair that may come down the line as well. And there are other novel agents that may stimulate the pathway we'll mention briefly as well. So in talking about gene therapy and replacement of ATP7B, this is some of the preclinical work that was done, and you'll see this appear in a couple of the different lectures here. But we have a saying in the medical world that people have to see things 3 times to actually absorb it. And so you're going to get a little repetition here, which is okay. So when you put back in ATP7B, what you would do is you can restore the ability to take copper that's in the liver and go out that biliary excretory pathway. And that is shown if you look at the figures over on the right. You're looking at sort of a PET imaging of radiocopper that goes into the liver, and all the way on the right you'll see that very red box that shows the liver at 24 hours and the same box at 48 hours where that hasn't changed. And this is in an animal model of Wilson disease. So you put the copper in, the copper stays in there. And now, if you look all the way to the left, you'll see that it's changed the shade. It's no longer red. It's now sort of a lightish blue, yellow, and then you'll start to see other color appear below that. And what that is the liver is pushing out the copper into the intestine, and this is in the wild-type animals, the non-affected animals. And then if you put in the gene therapy, what you start to see is the same effect as you have in the wild type. You start to see the copper appear into the bile, and the copper within the liver go down. It's no longer that shade of red. That's what's shown in the middle. And there's another secondary effect. When we look in the bloodstream, you can actually see the copper, which normally over time you put in, and if you don't have a mechanism to put the copper into the protein ceruloplasmin that circulates around as a copper protein, then the copper will decline that you add to the body, and that's radio-labeled over time. But if you restore that capability, and this is shown on the graph on the left side, you will then start to see successive lines where you can see increase in copper that occurs over a period of time, and that means the copper has gone into ceruloplasmin and goes back into circulation. So there are gene therapy trials ongoing, and Dr. Ascari will talk about that. So this is one way that we can put the copper back into bile. Now, there's also a very interesting agent. Dr. Toe had mentioned the methanobactin, which is a bacteria that lives in an environment where it utilizes methane as a substrate, and it makes these little molecules called methanobactin that are secreted by those bacteria that help it deal with copper in the environment. And if you take those methanobactin molecules, and it's a peptide, and you inject it into animals that have Wilson disease equivalent, you can actually rescue the animals. The liver damage goes away. And shown in the micrographs here, you can see the pictures of the mitochondria, which in this case are very damaged. And then if you give the compound and then you see restoration of a normal structure. And shown on the bottom are graphs that actually look at some of the molecules that are made within the mitochondria and show that you actually restore the function. But the really fascinating part, if you look at these pictures right here, you're looking at a heat map, basically, of the copper in the cells. And shown on the left is the red in an untreated animal model of Wilson disease. You see a lot of copper still in the cell. And after treatment with this compound, you can actually see a reduction. Now, how does this work its magic? Well, shown on the next slide is a PET imaging, similar to what I had shown you for the gene therapy, where you start to see, after you administer this compound to the animals, you start to see the appearance of copper in bile that goes out into the intestine. And that's how it's working to get that out. So this is still in a preclinical stage, but it hopes that this will also translate into human studies within the near future. So when we have these potential mechanisms, both introducing the gene and then also restoring the biliary copper, where should we go with this? And so one of the questions is, do we have to get back to the normal level? Does the lower curve have to be like the upper curve? It's a range and really depends on our intake and utilization. And the question is, what happens if it's higher? If we take too much out, what happens if it's lower? Do we actually meet a definition of a cure if we still have to have dietary restrictions? These are all questions that remain to be answered. And therapeutically, we talked about liver transplantation. Yes, we do restore the liver that has a normal ATP7B, but it's a lifetime of immune suppression. Gene therapy, the question is, can we get the adequate expression? Do we need regulation of that? And how long will it last? And the same thing in terms of methanobactin and other compounds that experimentally change biliary copper excretion. You know, how much do we need to do? How frequently do we need to do it? So when we talk about a cure and knowing we're there, we have two features. One is safety. We want things kind of like the Goldilocks principle, not too high, not too low. We have to be able to look for deficient states and also excess states. And the other part is efficacy, in that we can actually change the toxicity of the copper, reverse where it is, and also prevent future toxicity. And one of the questions that remains is, should our best marker be the bioavailable copper that we look in the circulation? Will that precede any of the clinical changes? Now, one of the exercises we did a couple of years ago, I'll finish up on this note, is I asked, and people were kind enough to respond from some of our board members from our association, what does it actually a cure mean to the patient? And so I'll just share some of the quotes. A cure for Wilson disease would have to be, 1, eliminating the need to take medicine for the rest of my life, 2, reverse residual neurologic systemic effects of the disease and have no serious side effects, be affordable. And sadly, this person believed such a cure is not a possibility in my remaining lifetime. The next respondent said, this question got me thinking, and the old saying, prevention is better than a cure, comes to mind. If we can prevent Wilson disease, then in fact, we have the cure. Certainly an important feature, and we'll hear more about screening for the disease shortly. The next respondent said, the way I look at a cure is not having lifelong treatment for Wilson disease. And again, this means that sort of permanence we spoke of. And then the last also spoke about that. To me, a cure is permanent absence of disease. Being free of disease symptoms and the need for therapy for a period of time would be wonderful, but it's not a cure unless it's a permanent cure, permanent effect. And this meets that definitional part. Now, another thinking was, what about having a cure and the impact? The impact for a cure was really to shift the focus of the mission to really increasing awareness, improving diagnostics, so that really then you've diagnosed the disease early and you prevent the organ damage that may be possible. And then the last one, which I found rather amusing, is a cure to me means never worrying about having an oyster and a glass of champagne without having to take medication 3 times a day. Yes. All right, so what does it mean to me? It means happy and healthy patients. That means I probably don't need to write another guideline for Wilson disease. And so I thank you, and again acknowledge our organizers, our sponsors for the meetings, our patients from whom we constantly learn, and our colleagues who make this possible. Thank you.